I'm Emily, and the other group members are Kaylee, Megan, and Maddie, and today we're going to talk about gas exchange, more specifically, COPD. So today we're going to discuss COPD. We're also going to go through the assessment, identify signs and symptoms that are related to COPD. We're going to discuss treatment options, both pharmacological and non-pharmacological forms. We're going to discuss diagnostic testing that is used to identify and diagnose COPD. And we're going to discuss possible nursing diagnosis and plan of care that is related to COPD. So as a brief overview, we know that gas exchange is defined as the transportation of oxygen to the cells and transportation of carbon dioxide back into the alveoli to be expelled. COPD, as we know, is a preventable chronic limitation of airflow, which can include both bronchitis, chronic bronchitis, and emphysema. This is most commonly caused by cigarette smoke, long-term exposure to air pollutants. Common symptoms are dyspnea, shortness of breath, sputum production, and frequent respiratory infections, coughing, as well as audible wheezing. Risk factors include being female, using tobacco, occupational chemicals, as well as both indoor and outdoor air pollutants. So here on the left, we have a healthy lung compared with, on the right side, we have a lung with COPD. So today we have Barry Alexander, a 57-year-old male presenting to the emergency department early this morning with complaints of coughing, shortness of breath, he's not able to speak using full sentences, mild suprasternal retractions, and chest pain. He frequently sits in the tripod position while awaiting care. So patient situation. Mr. Alexander has smoked 2 packs of cigarettes a day for the last 23 years. He was diagnosed with COPD 8 months ago. Mrs. Alexander stated that the acute exacerbation occurred shortly after he carried groceries up the front stairs into their 3-story house. He is currently living with his wife and his daughter. Mrs. and Mr. Alexander explained that he has been experiencing a persistent, productive cough for the last 3 weeks. His sputum is yellow-tinged. Mr. Alexander worked in a coal mine for 11 years, and he has been experiencing difficulty breathing when lying flat, now requiring 2 pillows for him to sleep comfortably. So the assessment. So we want to have a history for the current admission. So we know that he's smoking, and we know how often he's smoking 2 packs a day for the last 23 years. We know that he's been diagnosed with COPD for the last 8 months, so we would like to know if he's had a previous exacerbation, when was it, what induced that exacerbation, how long did it last. We do know that he's been experiencing current symptoms of this current exacerbation for the last 3 weeks. We also want to talk about medical, surgical, family, social history. So we want to know, does anybody else in his family have COPD? Does he have any other lung conditions? Has he had a recent lung infection or any other health concerns at all? As for the physical exam, our priority exam here would be to do vitals right away. So we're going to check his SpO2. Typically for COPD, their range for oxygen is 88 to 92. So we want to make sure that if we give him oxygen that we stay within that range, as going above 92 can remove the drive to breathe. Back to vital signs, so he's most likely going to be tachycardic as well as tachypnic. And at the same time, we're going to want to check his pain scale and do a pain assessment, as he said that he's also experiencing chest pain. So respiratory system. So we know that his respirations are going to increase. We want to auscultate the chest, both anterior and posteriorly. We want to note any adventitious sounds and abnormal findings. So we want to look for wheezing, decreased air entry, perhaps even barrel chest. So we just want to document those things. We also want to assess his cough. So is his cough harsh? Is it productive? So we know that he's having a productive cough. His sputum is yellow tinged. We want to know the consistency. So is it thick? Is it liquidy, thin? We want to know quantity as well as duration. Is he having difficulty breathing as well? And does anything make it better? So does he know about positioning, like tripod positioning, or even pursed lip breathing can help with dyspnea? And does anything make it worse? So he did state that he now has to use 2 pillows when laying down to be comfortable. And is there any pain with respiration? So he did state that he's currently having chest pain. Cardio, so we know that his heart rate's going to be increased. His color, he's probably going to be pale, even cyanosed. So check around the bottoms of the earlobes, tips of the nose, around the lips, as well as on the fingers. You're going to check his temperature, not just for vital signs, but you're going to feel if he's warm to the touch or he's cool. He might be cool and clammy, so he may not be dry. We're going to check his pulses as well. We're going to check cap refill. And we're also going to assess for clubbing. This is very common with chronic lung diseases. So yeah, we're going to check for that at the end of the fingers. And last but not least, we're going to assess neuro. So we're going to make sure that he's able to keep a conversation with us, that he's not groggy and he's not confused. We'll do a full GCS on him. And we want to make sure that he's oriented to person, place, and time. We also want to know any medications. So we want to know anything that he's taking at home, how often does he take it, and does he get any relief from it? And is he taking any over-the-counter medications? Allergies, we would also like to know if he has any allergies. And if the answer is yes, we do need to know the reaction that he experiences, whether that is mild, moderate, severe, or anaphylaxis.
Okay, so for the plan of care, we want to provide education regarding smoking cessation. Smoking aids in the progression of the disease and causes an inflammatory response in the lung. We want to maintain airway patency, management of dyspnea, and shortness of breath while also maintaining an oxygen saturation between 88 and 92%. So this can be done by encouraging deep breathing and coughing, as well as pursed lip breathing, and using an incentive spirometer. Also, encouraging an appropriate fluid intake will aid in the breakdown of those secretions. We want to avoid the risks of respiratory tract infections because people with COPD tend to be more susceptible to these kinds of infections. So basically just staying away from people that they know are sick and encouraging hand hygiene. We want to increase activity tolerance. This can be done with the management of the dyspnea and the shortness of breath. And we want the patient to have an understanding of COPD, which includes the signs and symptoms, risk factors, different treatment options, as well as creating an appropriate treatment regimen. So for diagnostics, the first one is a pulmonary function test. These are used to measure lung volumes and airflow while also helping diagnose pulmonary diseases and help monitor disease progression. So a spirometer is used and the patient is directed to take a really deep breath in and then exhale as long and as hard as they can. A normal percentage for an individual without COPD is between 80 and 120%. and then someone with severe COPD can fall around 50%. The next one is an arterial blood gas analysis. This is done to determine acid-base balance and the oxygenation status. The result of this analysis will often be respiratory acidosis because of the decrease in ventilation, which is causing a retention of all of that acid. The next one is a complete blood count, which is used to help identify oxygenation status when looking at things like hemoglobin and hematocrit. So these will tend to be lower, as well as potentially an increase in white blood cells, which may be indicating a possible respiratory tract infection. And then the next one is a chest x-ray, which aids in the diagnosis of COPD, although it is common that the early stages it might not appear on image. However, an image can show enlarged lungs and a flattened diaphragm, and even a lower kind of set diaphragm because of the extra pressure from the lungs.
So for pharm treatment, there's no actual pharmacological treatment for COPD. So the treatment is symptomatic and is mainly based on bronchodilators, such as selective beta-2 adrenergic agonists, both short and long-acting, anticholinergics, theophylline, or a combination of these drugs. Bronchodilators such as albuterol work by causing the muscles around your airways to relax. This can help relieve the coughing and shortness of breath someone experiences with COPD and makes it easier for the person to breathe. Another drug that is used is inhaled steroids. So something like corticosteroids medications can be used to reduce airway inflammation, and they help to prevent exacerbations. These medications are useful for people with frequent exacerbations of COPD, and an example of an inhaled steroid is the Flovent HFA inhaler. Another thing that can be used is combination inhalers. So some medications combine bronchodilators and inhaled steroids. So an example would be fluticasone and vilanterol. And another combination inhaler is one that includes more than one type of bronchodilator. And an example of this would be an inhaler with both albuterol and ipratropium. Another drug that can be used is oral steroids. So the oral steroids are used for people when the periods of time their COPD becomes more severe, called moderate or severe acute exacerbation. Short courses of oral corticosteroids can prevent further worsening of COPD. And the most common oral steroids used for COPD are prednisone, hydrocortisone, and prednisolone. And the last pharm treatment is phosphodiesterase 4 inhibitors. These drugs work by decreasing airway inflammation and relaxing the airways, and an example of this medication is roflumilast. So for the non-pharmacological treatment, the first thing would be smoking cessation. When somebody is diagnosed with COPD, the cessation of smoking is the most effective way to slow down the progression of COPD while also reducing the mortality rate. Another thing that they can do is oxygen therapy. It's used for the treatment of low blood oxygen levels or sudden shortness of breath. Oxygen therapy is most commonly used once the COPD has become more severe and the patient is getting out of breath easier and it affects their daily living. Non-invasive ventilation. So this is when air with added oxygen is given to the patient through a nasal mask, a face mask, or a helmet. Non-invasive ventilation is used when a patient's medical treatment is failing and they are suffering from persistent hypercapnic ventilatory failure and acidosis during an exacerbation. So it can help reduce the work of breathing and decrease their respiration. Some severe cases, they all might receive a lung transplant. So this is a procedure when one or both lungs of a person with COPD is replaced by a donor.
This is not a cure, but it helps with the management of symptoms and can help a person live a longer life with COPD. And they are usually only given to someone who is suffering from a severe case, and this is their last chance of surviving. And then the last non-firm treatment is a lung volume reduction surgery. So this is a surgery that is done to help improve a person's breathing. They remove small pieces of the damaged tissue to help the remaining lung tissue function better and make the breathing easier for the person. And then other treatment options are immunizations and antibiotics. So immunizations are recommended for a person with COPD, so such as like the flu vaccine and the pneumococcal vaccine. Someone with COPD can be affected more severely by sickness, and becoming sick can make their symptoms worse. So we want to do everything we can to reduce their chances of getting sick. And antibiotics, so people with COPD are prone to contracting respiratory infections. Respiratory infections can make the symptoms of COPD way worse. And antibiotics help treat these episodes of worsening COPD, but they are not generally recommended for prevention. Some studies do show that certain antibiotics, such as azithromycin, prevent episodes of worsening COPD, but side effects and antibiotic resistance may limit their use. So then some nursing interventions. So the first one would be breathing exercises. So things like pursed lip breathing and deep breathing exercises can help strengthen the breathing muscles, get the body more oxygen, and help the person breathe with less effort. Pursed lip breathing, deep breathing, and diaphragmatic breathing are examples of breathing exercises. Direct or controlled coughing is another thing that they can do. So someone with COPD, they have excess mucus, so they are coughing all the time. To help with coughing up this mucus, the patient can use direct or controlled coughing. This is more effective and reduces fatigue associated with non-effective forceful coughing. So somebody with COPD would want to manage their daily activities. It is easy for a person with COPD to become exhausted or suffer an exacerbation while doing their daily activities. So their daily activities should be paced throughout the day, and things like support devices could be also used to help decrease their energy expenditure. Exercise training and planning is also done for somebody with COPD. So exercise planning is when the doctor makes an exercise plan for the patient to follow. Exercise training can help strengthen the muscles of the upper and lower extremities and improve exercise tolerance and endurance, which will help decrease the chances of exhaustion and exacerbation. So with somebody with COPD, you would want to monitor their breathing and respirations. We want to monitor a person's breathing when they suffer from COPD to make sure that they are healthy as can be and they are not suffering an exacerbation. So things like their resting respiratory rate and their pulse oximetry should be monitored constantly to catch any problems as early as possible so that treatment can be started right away. It can also help for the head of the bed to be slightly elevated. Sleeping and sitting in this position can help ease symptoms such as shortness of breath. And sleeping with the head of the bed, sleeping with the head of the bed elevated helps with a clear airflow and helps prevent obstructions. Another reason this is a good position is that it helps with acid reflux, which is a frequent problem in patients with COPD. Another thing that's done with the COPD patient is a consult with the interdisciplinary team. So someone suffering from COPD can have many health problems. They might not just suffer from trouble breathing. They could also suffer from things like GERD, osteoporosis, depression, or heart problems. So you need a team that can help the person with all the problems they are suffering from so that they are getting the best treatment possible. And then the last nursing intervention is pulmonary rehabilitation. So pulmonary rehabilitation are
a combination of an exercise plan and patient education. So it does not reverse the damage to a person's lungs caused by COPD, but it can help improve lung function. It helps reduce the severity of the symptoms, and it can improve the person's quality of life.
So next we have the evaluation. So patient has received smoking cessation education and has potentially joined a program. A patent airway has been maintained with no significant increase in sputum production. Patient has maintained an oxygen saturation between 88 and 92%. Patient reports an increase in activity tolerance with a decrease in shortness of breath and dyspnea. Patient reports the use of effective breathing exercises such as pursed lip breathing and deep breathing with an incentive spirometer. Patient demonstrates an appropriate understanding of what COPD actually is, which includes risk factors, signs and symptoms, and the treatment regimen, and a treatment regimen is being followed appropriately. So next are some nursing diagnoses. So the first one is activity intolerance related to an imbalance between oxygen supply and oxygen demand, as evidenced by dyspnea and shortness of breath during activities of daily living. Ineffective airway clearance related to an increase in sputum production, as evidenced by dyspnea, shortness of breath, and a productive cough. Impaired gas exchange related to decreased ventilation, as evidenced by respiratory acidosis, shortness of breath, and dyspnea. And the last one is readiness for enhanced knowledge related to recent diagnosis of COPD, as evidenced by smoking cessation and adhering to treatment regimen.
Okay, so when we searched the literature, we wanted to narrow our search down to coal miners who experienced COPD because our patient Barry, he was a coal miner for 11 years. So we wanted to see if that had any relation to why he has COPD. And we found this article here that says high exposure mining occupations are associated with obstructive lung disease. So for a long time, like studies have shown that coal mining is in fact like contributing to chronic lung conditions, but oftentimes they talk about how it contributes to chronic bronchitis and emphysema and not so much COPD. So that's kind of why we wanted to look further into this. And this study actually states that coal mining is actually more prevalent in COPD patients. So it was actually second of the 4 that they studied, like the second highest percentage. So the first was asthma, and 9.9% of the people that they interviewed had asthma, and then 6.2% of the people that they interviewed had, I think it's 6.2, had COPD. And then even lower were the chronic bronchitis and emphysema. So we thought that was kind of interesting because there's not many studies that say that. So that's why we wanted to find one that did. So yeah, that's that for that one. So the developmental stage considerations. So we'll focus on Erickson's stage in a second. We just wanted to note that when he's 57 years old, so at that age, they're having issues with mobility already. So like aging causes physical changes in your body. So his lungs may have trouble retracting and recoiling anyways. And then with COPD added onto it, it makes it really hard to breathe for him. Like it says there, the respiratory muscles are weaker, and his immune response is weaker as well. And then, yeah, so they were exposed to more pollutions over the years. So if a person is older, they may have been exposed to coal mining a lot because we, as younger people, aren't, because we don't have that really anymore. But regarding Erickson's stage, this is a stage of generativity versus stagnation. So generativity means that they want to be productive members of society. They want to succeed in their jobs that they're doing, and they want to be able to help with their families. Maybe they want to run around with grandchildren or their children, and having COPD can really impede that. So that leads to stagnation. So we want to make sure that Barry has this managed so that he's able to do those things. And the next one, so to relate this to all these other concepts, there's definitely more than this, but we decided to focus on these ones specifically. So when we're talking about perfusion, like Emily said, COPD can lead to cyanosis, because if a person has COPD, obviously their blood is not being oxygenated enough because they're having trouble breathing. And then their acid-base balance is also going to be altered, because when a person has COPD, they have more CO2 entering their lungs because of how much they're trying to take in, because they're really hungry for air. So that can lead to respiratory acidosis, but also the anxiety that is caused by COPD can lead to hyperventilation, which can then lead to metabolic acidosis. And then fatigue, obviously a person with COPD who is struggling to take in air and can't do things as quickly as those without COPD, like walking around and carrying groceries up his steps like Barry. He's easily fatigued, so that can contribute. And then mobility, like it's hard for them to exercise like a normal person would. And the way it relates to nutrition is if they're easily fatigued, then they can't spend a whole lot of time eating big meals, because they'll get tired fast because of how much they're trying to breathe while they're eating. So it's important for them to have small meals that are maybe more nutritious and higher in protein and higher in calories. So that's that. And then the exemplars that we chose around gas exchange are COPD, which is the one that we decided to do. But there's also many others like chronic bronchitis, emphysema, asthma, cystic fibrosis, and pneumothoraxes. So to review the learning objectives, we went over the signs and symptoms and the diagnostic criteria. We went over some nursing diagnoses. We went over pharmacological and non-pharmacological treatments and other treatment options. Talked about nursing interventions that we can do to help them, and patient teaching as well. And our anticipated outcomes for Barry, we want him to be able to explain to us what COPD is and how we can treat that, and how he can treat it himself at home. We want him to be able to list the signs and symptoms and know when he should go into a doctor or go into the hospital, like if he's having an exacerbation. We want him to follow his treatment regimen, so be able to maybe develop an exercise plan and stick to that exercise plan, or alter it if needed. And same with his nutrition as well. And then one important thing is when he's a cigarette smoker, so we want him to talk about the importance of tobacco cessation, and maybe he'll attend a program that will help him stop smoking, and hopefully that will help him. And now on to the questions.
So some questions we have are, what are some factors that put Barry at a higher risk for developing COPD? So risk factors for Barry specifically would be working in the mine as well as smoking. Our next question is, would COPD cause respiratory acidosis or alkalosis? So we talked about how the alveoli in a person with COPD doesn't have the ability to deflate or collapse, which allows the carbon dioxide to remain within the lungs. So this contributes to respiratory acidosis. What might an exercise plan include for Barry? So exercising is very important because we want them to be able to maintain their ADLs, but it is very specific to each individual patient. There is a test called the, I believe it's the 6-minute walking test, and they have to try and get to about 300 meters within the 6 minutes. And if they are not able to do so, it's an indication to a healthcare professional that this person is in significant distress, that they're having a hard time moving at a significant pace, which could inhibit their daily activities even further. So yeah.
All right, so these are just our references here. Thank you for watching, Melina and Claudette.